I'm Dr. Rick Lindquist at Swedish Weight Loss Services here in Seattle. I'm an obesity medicine specialist, and I'm here with my friend today, Dr. Samar Mattar.
Thank you, Rick. And my name is Samar Mattar. I'm the medical director of Surgical Weight Loss Services at Swedish, and I'm a bariatric surgeon. I'm so happy to be here, and we're so happy that you've joined us. So, Rick, I've been doing this for nearly 16, 17 years, and I know I couldn't think of a better job. I mean, it's so rewarding. But tell me, what made you join and choose this profession?
Well, that's a good question, and it starts with the fact that I have a weight problem myself, and I work at it every single day. And as I got some help for it 15 years ago, and I managed to lose some weight and keep it off, it developed into just a real passion and love for the field. It's one of the large epidemics of our era, and if we don't take care of this epidemic of overweight and obesity and the complications of it, diabetes, etc., we're going to have big problems. So it's just a lot of fun, and our patients are fun, and it's just a great field to be in.
Absolutely, that's been my sentiments too, and my experience. As surgeons, we're probably more goal-oriented a little bit, and we like to see solutions. And I can tell you, it is so rewarding to deliver one kind of therapy, one kind of treatment to a patient that resolves so many medical issues, also improves quality of life, and improves also their morale and well-being and maybe a happiness factor as well.
Absolutely. So how do you come to be here at Swedish, and what is it about working at Swedish that you love?
So I joined Swedish about 2 years ago. Prior to that, I was a professor of surgery at Oregon Health and Science University, and before that in some other universities. And what drew me to Swedish is really all the resources that they had accumulated and put in place for our particular patients. As you know, our patients have special needs. They have multiple, in some cases, medical comorbidities, which require a multidisciplinary approach. And what I mean by that is obviously surgeons and physicians, and also dietitians, psychologists, nurses, physical trainers, the whole gamut. And when I came here, I was frankly very impressed with the space that was allocated for the program and the people who were allocated to the program. And I thought this was an area where if I came, I could help advance the mission of treating these very deserving people in meaningful, durable ways.
Yeah. Well, that speaks to one of the key concepts that we use in our field and that we share in both medical weight management and surgical management is this idea of a care continuum, right? Because there's no one perfect way to fix everything, right? So we work, and this is the beauty of a comprehensive program. We have nutritional services. We can talk about behavior change and adult learning. We can talk about medications. We can talk about activity and exercise, and we can talk about surgery. So what type of surgeries do we do at Swedish?
So we mainly do two types of operations. One is the Roux-en-Y gastric bypass, which is an operation that's been around for 50 years now. And the only difference, the change that has come into play is the approach. We now do all our operations laparoscopically, which is keyhole surgery. As you know, we don't cut patients open anymore. Right. But the more popular operation, the one that we're doing more often, is the sleeve gastrectomy. And the way I explain it to patients is we take the patient's stomach, which is typically the size and shape of a football, and make it into the size and shape of a banana or a hot dog. And they both are very effective operations. They're both safe. They're both are powerful in terms of inhibiting hunger or appetite, and they're well tolerated by patients. So, yeah, and back to the continuum of care that we do. I think it's very important that we not silo the patient in one area, that we tend to collaborate in the care of the patient. And just like you offer many different types of medical therapy and I offer surgical therapy, I think the whole concept is that we personalize our approach to patients, because every patient is different.
That's right.
If there's one thing that I learned over the years, is that you can't treat them all the same way. Everybody is a little different and needs a little bit fine-tuning and customization. And I think this is our strength.
I
This
think
is
you're
what we
right.
do very well.
So I brought a prop. I want to share my prop.
Yeah,
Okay.
I love it.
This is 5 pounds of fat. Now this is rubber, but I've weighed this and it actually really is 5 pounds. But why did I bring this prop? Because I think it's important to realize that we are coming to better understandings of the disease of obesity and the disease of overweight and what fat tissue does. And that actually what we have in common, even though one is surgical, one is medical, is that we treat the metabolic issues that patients have. So when we do a medical intervention and work with people to lose weight medically, we see their metabolic problems improve. We are able to reduce or eliminate insulin, for example, sometimes. Not all the time, but often. We're able to help with things like sleep apnea, with things like high blood pressure, and improve the medical problems and treat the quality of life as well. And I know that that's what happens on surgery. In fact, the organization changed their name from the bariatric surgery
To metabolic.
to metabolic.
Again, to emphasize the importance of what we do and how it improves all these disease states, most of which are both silent and life-threatening.
Right.
I mean, I think many of our listeners, are aware how dangerous it can be to have uncontrolled diabetes, uncontrolled sleep apnea, uncontrolled heart disease, hypertension, and so on. These can be life-threatening. And that is what's so satisfying about what we do, is that one approach or multiple approaches within the same context can so dramatically improve this. So tell me, Rick, do you what criteria? What criteria does the patient have to be referred to see you?
Well, that's another good question. So we take direct referrals. People can come in, self-refer into our clinic, or we take referrals from their healthcare provider. And I think that honestly, if anyone's concerned about their weight, I think we could probably have the conversation. People don't have to have a particular body mass index to use our services. We, in fact, focus more on the conditions that they have and the reasons for wanting to improve. Impaired activities of daily living, shortness of breath, arthritic pain, poor ambulation, diabetes, sleep apnea, those other things. So really, we don't have any specific criteria that we have to meet. I think one thing I'd really like to bring out, and this is important, I think, is that if someone's interested or concerned about getting help for their weight, have the conversation with their primary care provider.
Absolutely.
Ask for a referral. Ask for what other resources, even if they don't come to us, right? People who struggle with their weight, we need resources. We need help. And there's no one fit that's perfect for everybody. But have the conversation with the healthcare provider. That's the first start. But we take referrals or we take direct referrals to the clinic.
Great. So I'm actually going to interject here because we have a few questions.
Yes.
But I want to thank both of you so much for joining us today. And you touched on this a little bit, Dr. Lindquist, but the question from one of our listeners was, what does a patient journey look like with Swedish Weight Loss Services, and how do I get started?
So it kind of depends on which pathway they're going to come in. If they know they want to go the bariatric surgery route, and a lot of people want to explore that and know that, the first step. I said we can also go online now, right?
Right. So the first thing to do really is to go to our website, and the website is available, I think, on the Facebook. And then once they get into the website, they have a choice. They can either go to one of our in-person seminars, which are held in many locations in the region, or they can go online, which is what I would recommend if that's something that interests them, because it allows them to have this at home. And overcome some of the logistic issues. Once they've done the seminar, whether in person or online, then we take their information and just check for insurance benefits, and then from then they come and see us for initial evaluation.
Right.
Now, and on the medical side, it's very similar but a little bit different. We are a little bit we're dark on medical seminars right now, but we're going to restart them again in the spring. There's a history and physical form the patient fills out. We spend a lot of time with them. We spend a minimum of an hour with the clinician on that first visit. So, budget plenty of time. This is not come in, get your weight loss, and leave.
Right.
And we have this cool evaluation process. I think we look and see what labs they've had, order any labs that people measures your body composition.
Yeah.
It tells you not only how much you weigh, but how much of And then, as I say, the very first visit's about an hour at least. And then we have people back on a regular, periodic basis, roughly monthly in the medical arm. And we do take care of some of the patients that will also be in the surgical arm. So we might provide some medical care for them as well.
Exactly.
If they're
So
over
the whole pathway process, if you will, is one of evaluation and optimization. What we mean by that is they get seen by a medical provider, they also get seen by a dietitian, and eventually they get seen by a psychologist as well, so that we have a complete, holistic, comprehensive evaluation of the patients. And then it's not a rushed job. We don't rush into surgery. We take our time and prepare them mentally and physically for all the dramatic changes that they're going to undergo both before and after surgery. And so it's a timely process. It's not over long. It's between 3 to 4 months, depending on some insurance requirements as well. But it's time well spent in preparing for a lifelong, a life of good health and well-being.
Now, a quick question about the surgical component. So are there some people that might be candidates and some people that might not be candidates, and what does that look like?
Thank you. So there are criteria that we have to comply with or follow, and these are criteria that were drafted by the NIH, the National Institute of Health, many years ago, and they haven't changed. And these are the criteria that are followed by the insurance companies as well. The most important one is the BMI, or body mass index, which, as you might know, is a formula that includes a patient's weight in kilograms with their height in meters squared, but they can get this off our BMI calculator that's on our website. So the BMI has to be above 40, or it could be above 35, but with maybe one or two of those life-threatening conditions that I mentioned, the major diseases, the diabetes, the heart rate, the sleep apnea, and so on, the blood pressure. And basically, they need to understand what they're getting into, and this is where a lot of the counseling goes, and we just need to improve their health and optimize it in preparation for surgery. Are there candidates who are absolutely not ready for surgery? Those are the ones who might have some substance abuse issues that are still in effect. But by and large, we pretty much help everyone who needs help.
Great. And so if someone came to Swedish Weight Loss Services and they decided they move forward with a gastric bypass or something like that, what does the ongoing support? Are they still going to come back and receive emotional support, nutrition advice, things like that?
So one thing that's very characteristic of our program is that we never discharge anybody. It's a lifelong relationship that we develop with the patients, because we're all humans and we all need lifelong support. And this is what we're strong at. We provide nutritional support and psychological support for patients thereafter forever. And there are patients who, frankly, will do very well, and others that might struggle later on in life. And this is why we're there available for them to try and overcome these challenges early on. Also, this is where I use the help of my colleague, Dr. Lindquist, in that if I have patients who've had surgery and might be struggling with a little bit of weight regain or other challenges, I come to Dr. Lindquist and say, hey, I have this patient who needs help, and then you're able to help with that.
Exactly. And, a person goes through the surgical process, they have their surgery, and then they go through the period of time after the surgery. And there's a period in there at some point where they're not really surgical patients anymore, in the sense that they don't need a surgery. What they need is medical follow-up. And that's one of the strengths of having a comprehensive program. We're fortunate to have a really great crew of advanced practice clinicians, nurse practitioners, and PAs, physician's assistants. And all of those folks and myself were able to help work with this medical care subsequent to that. And it's I got to say, it's a really fascinating and fun area of medicine because we help people. I worked in the emergency room for a long time, and that was very satisfying as well. But there, people kind of yell at you and they do and say not so nice things to you. You know, we develop relationships with our patients over time, and I get lots of hugs, and I'm sure Sam does
I
as well.
do, and
Yeah.
there's nothing more gratifying. It's what I like to get paid in. Is hugs.
That's fantastic. So I know you mentioned there's a lot of different patient journeys for how someone would come to Swedish Weight Loss Services, but when do you think is critical for some kind of intervention in weight loss? When is it at the point where someone really should be getting medical attention?
Yeah.
So with regards to surgery, the earlier the better, because we've learned over the years that postponing surgery doesn't really help unless we're in the process of optimizing the patient. But in general, the medical conditions that patients come with, they tend to get worse as you wait longer and longer. So we really advocate that patients come in early on in the process before their advances have advanced, the diabetes, the sleep apnea, the hypertension, and the cholesterolemia, all these things. So if there's one message I want to get out there is the earlier, the better.
Yeah. And that speaks to the fact that in both the surgical side and the medical side, only a very small percentage of people who could potentially benefit ever seek help or are referred for help. So for me, it comes back again to that early conversation and be involved early. Look for resources and look for ways to get some help. Many of the patients who wind up in, I think, either of our sections have often feel like failures. They've lost weight only to regain, lost weight only to regain, and uh, and have internalized a certain sense of failure, which I understand. But I think one of the things we try to do is normalize the fact that no, your body's responding metabolically the way that it's being given those inputs. So we try to normalize with patients. Say, look, here you got.
This is not your fault.
It's not your fault. You got a life. Your life works. You got a really good life. All these other aspects of your life work, but you feel like a failure in this one area. A little bit of cognitive dissonance there. Right? Let's see what we can do to help you structure whatever type of approach is best for you.
I agree with you, Rick, entirely. We need to keep honing in the message that this is a disease. This is not your fault. This is not a character flaw or a personality trait. You came to us with a problem, a medical problem, which we are going to help you with. Because, it's sad to say, only a very small percentage of deserving patients come to see us. What do you think is the reason for that? Why are patients a little, reluctant both to come see us or to be referred by their doctor?
Well, I think the basic referral process is one problem that there's not necessarily an awareness of the fact that the services are available, and that when people come in our door, they don't automatically come in on a Monday and get surgery on a Wednesday. We go through the process. So a misunderstanding. I think that there's a certain stigma out there. I think that people feel they know it's a problem, but a lot of people feel like it's their own problem, right? They don't get medical help with it. And I think that insurance coverage is a big issue.
Yes.
So
it's a little sad.
It's a little sad, but I think we're making progress.
We are. Every day we're making a little more progress. Yeah.
Great. Well, Dr. Mattar, we have a question for you.
Yes, sir. Yeah, ma'am.
What is the recovery like after surgery?
Right. So the operations themselves take about, for the sleeve gastrectomy, takes about an hour. Gastric bypass, maybe 2 to 3 hours. And most patients are in the hospital for 1 or 2 nights. And then it takes about 2 to 3 weeks to get back to feeling normal. The limiting factor is going to be mostly in terms of their ability to concentrate and make decisions, not as much in physical exertion. And most patients are able to go back to work in, like I said, 2 to 3 weeks, maybe occasionally 4. And it takes about 4 to 6 weeks for their energy levels to return to where they were before surgery, and then they go through the roof. In terms of the diet, we place patients on liquids for the first 2 weeks after surgery, and then our dietitians start incorporating more solid foods into the process, so that by a month they're definitely on a regular diet by then. Of course, by regular diet, I mean healthy food. And our patients and our listeners don't need to worry about too much what that means, because our dietitians do a fantastic job in educating our patients on where and how to find food and prepare food in convenient and tasty ways. I think they
Right.
do a good job, and especially with their cooking classes. They have one on Facebook Live that I know is very popular, and other activities and our support groups. And there are many, many opportunities for our patients to feel supported.
That's great. That's fantastic. So we've heard a lot about the surgical side. Can you talk a little bit, Dr. Lindquist, about the journey and what that looks like on the medical side? I know you've touched on it, but can you give a little bit more of a story of what patients can expect with medical treatment for weight loss?
Yeah, I think the first visit patients come in, we spend a lot of time talking about the science behind weight management or the physiology of it. And I think that because people tend to internalize a lot of failure into the process, the first thing we do is start to what I call normalizing. We say, look, here's how your body works. Here's what happens when you eat protein, carbohydrates, fats, and alcohol. And here's the way your body metabolizes those things. And here's how weight is gained. And here's how weight is lost or maintained if it's not lost. And so then the dietary types of interventions that we discuss flow off of that. I focus a lot on adult learning as well. And if you think about how do people learn skills? Well, you don't learn skills right away. There's an introductory period. It takes, I'll tell patients this type of language. I'll say it takes 3 to 4 months to really start to pattern some of the basic behaviors in any type of a new skill. It takes another few months to start to gain some expertise and some facility, some usefulness of it. And then from there, you build additional advanced skills. And I think it takes a period of a couple of years to really go through the process and learn something deeply. And then, of course, there's maintenance. So I tell patients that this is a journey, that it doesn't end. I have a weight issue that I have to work with every single day, and I have for the last 15 years, and that it's okay. There is no, so that I think sets realistically the expectation that you've got it, there's learning, but guess what? It's doable, and you can learn it because you're not broken, because the rest of your life works reasonably well. So let's anticipate having a structure that will work for you. So again, our new visit is typically an hour. Our subsequent visits are scheduled for 30 minutes, and we spend typically over half of that in direct counseling and coaching work. And we work a lot around things like how to handle cravings, how to structure travel, how to get through holidays,
Yeah,
right?
absolutely.
So, and there's a little hint, one hint that works a lot around holidays is never go to a social event hungry.
Yes.
Eat before you go so that when you get there, you can actually socialize.
There's food everywhere.
There's food everywhere. It's a food tsunami.
So, one of the issues that we've had with surgery is our past. We've had a checkered past, and there were questions about the safety of surgery. And now we've improved our safety outcomes to a level that it's become as safe as natural childbirth. We're at that stage. Now, medications, I know, have had a checkered past as well.
Yeah.
Do you prescribe? Tell me a little bit about the prescriptions or the medications that you prescribe and their safety.
Right. Well, so, I think part of the stigma of weight has transferred over into a little stigma of people who take care of people with weight. And it has been challenged by some of the issues that were involved with earlier medications. Way back in the day, amphetamines, speed, were used for weight loss. Well, that's not such a good idea because they're addicting drugs, right? And then in the early 90s, we had this medication combination called fen-phen. Unfortunately, one of the medications in that combination caused heart valve problems. And fortunately, when you stopped them, they went away. But that type of issue with medications has, and a lack of understanding of what's available, has led to an underutilization of medications. At this point in time, we have some very effective medications. We have some of the older so-called sympathomimetic drugs, the drugs that are mild stimulants. They don't act like amphetamines. They don't create addiction. There's no withdrawal. So those are safe. And since 2012, we've had a number of other prescription medications that are approved. I'll name some specific names. There's the Contrave, there's Qsymia, there's Belviq, there's Saxenda.
Lots of options.
So we have more options available to us. And And we can usually find something. If people need help with hunger, we can usually find something to help them.
I don't know about you, but I often, I'm sure you as I have particular patients that come to mind who really benefited from what I do. I can recall a patient that I knew who was on 1,000 units of insulin a day.
Oh, man.
1,000 units. He had a pacemaker and a defibrillator, and they were both kick off almost daily. And we gave him a gastric bypass, and within 3 months, he was off his insulin entirely.
That's impressive.
Do you have a patient that comes to mind?
Well,
also?
I admire the surgical results that you guys get because they're really fast and they happen dramatically. You know, my area of work is a little bit slower over a period of time, but I think what I see that is really nice is somebody comes in and I give you an example. Day one, patient came in. We put her on in this case, it was a reduced carbohydrate type of structured approach. And she very, very motivated. She was on 80 units of insulin a day, nothing like 1,000, and was on glipizide, was on 2 other medications. And we stopped her glipizide. We cut her insulin from 80 to 60 and saw her back in 4 weeks. And her blood sugars were the best that they've been in several years. This last time I saw her yesterday or day before, we took her down to 40 units. Great. And she continues to improve. So
this is what I love about what we do.
Yeah.
That's great. Yeah. So we have a lot of questions, and you guys have a lot of fans also that are tuned in today. So Cheyenne asks, what are the biggest causes of regaining weight? Yeah. I know that's a loaded question.
Yeah. I think, like anything else, there are many factors that can influence the possible return of weight. I think stress is a big one. Mm-hmm. We all deal with stress in different ways, and there are healthy ways of dealing with stress and unhealthy ways. And we find stress is a very big factor, and this is where we sit with the patient. Whenever we see a patient who is struggling or actually regaining weight, we take our time and try and go through all the potential reasons for this happening. And then we act on them. Of course, our dietitians play a big role. Our psychologists play a big role. And I refer to my partner, Dr. Lindquist, as well, for his advice on how to best reverse this trend that patients might be getting challenged in.
Mm-hmm. Mm-hmm. No, that's right. And I think you talked about sleep and stress, or about stress, and I think that there are anything that can push a people off of their core strategy can lead to regain. The people who do best long term are the people who stick to their basic core strategy of appropriate foods, eat enough for satiety, for hunger control, don't get too fancy. And what are the things that push people off that path? Complacency can be one. So we talk about that. Sleep, stress, mood, all those things that can push people off the mark are important as well. So,
what about family support?
Hugely important.
I think so too.
I think, you really have to have a supportive family who are willing to just let you do what you need to do in order to have success. And we get a lot of, in the medical side, and I think you probably do in the surgical side as well, we get a fair number of patients whose families experience this halo effect. I had a patient come in a couple of days ago who, actually happens to be the patient with the insulin that I just mentioned. Yes. Her husband's been doing this same type of program.
Because they observe.
They observe, and she took the materials home. They went through it together. He's lost 30 or 35 pounds.
I find this a lot,
So that's pretty exciting.
Also, if the patient is the meal preparer at home, the whole family tends to get healthier. One thing we've noticed also is the offspring of patients that we treat tend to be healthier as well. The babies are born healthier and smaller than those that have not received treatment.
That's great.
Yes, it is.
So we have another question from Jill. I had heard once that the standard BMI numbers may be misleading for people of Asian descent, that people of Asian descent actually should be at a lower BMI than what appears as normal or average. Is that true?
Absolutely true.
Yeah.
She is correct, right on. And in fact, the World Health Organization came up with a new classification, and they recommended that patients of Asian descent they be considered obese at BMI of 27, morbidly obese, rather than 35, like we do with non-Asians.
Yeah, and in our field, it's kind of interesting. We use BMI all the time, But honestly, I don't want to speak for you, but I don't think it's a particularly important number in many ways because it doesn't tell you if this stuff is functioning properly or malfunctioning. And really, if we look at it from a metabolic perspective, the BMI was developed in 1832 by a Belgian mathematician who lived in France. And it was Adolphe Coutelet.
Yeah.
And he was asked to come up with some numbers for insurance usage for what mortality rates would be. And it was resuscitated, in like the 60s, I think, by Ansel Keys or something.
Yeah.
So we do use BMI, but
we have to abide by it for now. But we're hoping to change that in the future. Just to continue on Jill's question, the reason why 27, I believe 27 or 28, I can't remember, is reserved for patients of Asian descent is that it was found that those medical conditions that I mentioned, they tend to latch on, they tend to link on earlier in this population. That's why it has to be addressed earlier.
Does that apply to any other ethnicities?
As far as I know, it's just for the Asian and Asian descent.
Right.
Asian races.
But the BMI, we always have to take it in context. You can have a BMI of 35 and be sick and have diabetes, or you can have a BMI of 35 and have 12% body fat, which is low, and be a linebacker for the Seahawks. So it's not just the BMI; it's actually the composition.
And then the BMI changes with age as well.
Absolutely.
Yeah.
Okay.
And gender. The composition.
So we have one last question, then we're going to wrap it up for today. But thank you both so much.
We're having so much
Already?
fun.
No, we need to do another one of these. So Jill has another question. Do you still have to go to a seminar first before getting an appointment?
Well, as I mentioned, there are two options. Yes, the short answer is yes. But she can either go to an inpatient seminar or attend our online seminar, which really is about, I think, 20-25 minutes in duration. But yes, we want patients to attend the seminar so that they can get an overall impression of what to expect.
Now that's true on the surgical side. On the medical side, there's no required seminar.
Right.
We just call, make an appointment. We're extended out for new appointments, but we're working on that too.
Great. Well, thank you both so
You're
much
welcome. Thank
today,
you.
and thank you for everyone that tuned in today. The recording will be available after the live today, so you can rewatch. And I hope everyone has happy holidays.
Thank you. Merry Christmas,
Thanks to
everybody.
who attended.
Yeah.
Thank you.